Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is the role of laser in the treatment of glaucoma with Dr. Nate Lighthizer, who's a graduate of Pacific University College of Optometry, and he did a residency in family practice optometry with an emphasis in ocular disease and surgical laser procedures through NSU Oklahoma College of Optometry. He joined the faculty of the Oklahoma College of Optometry and served as chief of specialty care clinics, chief of electrodiagnostic clinics, director of continuing education, and head of dry eye clinic. He was recently named the dean of the College of Optometry in Oklahoma. He lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular diseases. It's going to be a very interesting talk on lasers, and for those who may not be aware, this is a perfect situation, with laser being light amplification through the stimulator emission of radiation. And what better person to talk about laser than a person named Lighthizer? So, Nate, please take it away.
Oh, Joe, you are so funny. Thank you, sir. Appreciate Greg and Joe, the very kind introduction and the invitation to lecture at yet again one of your webinars. I always enjoy it. And I'm looking forward to chatting with all of you tonight. Let's have as much interaction as possible. If you have any questions, type them in via the chat box or whatever they said there for the questions, and we'll pause at numerous points throughout this webinar to discuss. And I love hearing Greg's feedback and Joe's feedback as we go throughout this webinar and their points of view as well. So again, my name is Nate Lighthizer, faculty member at the Oklahoma College of Optometry. I do a number of different laser procedures, did 8 of them yesterday afternoon. That included PIs, SLTs, capsulotomy, and laser floater removal. And then this morning I was in OD surgery clinic with that radio frequency device. It used to be called an Elman unit, as Greg said. Now it's called a Sonoquence unit. Same thing. And we were removing eyelashes this morning with radio frequency, lumps and bumps, skin tags, cysts. So it's definitely where optometry is pushing forward into more of the office-based procedures, laser procedures, injections, minor surgical procedures, whatever you like to call that. So again, that's the talk tonight is the role of laser in the treatment of glaucoma. We are mainly going to talk on laser trabeculoplasty. We will probably, depending on how long and how many questions you guys have, touch on peripheral iridotomy at the end as well. Those are our 2 main lasers when it comes to glaucoma. So that's the other topic of lasers and optometry, the next frontier. It's that's where we're going forward. So there's my disclosures there. We'll keep this within the guidelines of a COPE approved lecture. We're going to skip the poll everywhere, so don't worry about that at all when it comes to poll everywhere. So again, overview: laser trabeculoplasty and laser peripheral iridotomy. And I always start with this slide. And then there were 3. What do I mean by that? Well, there had to be a first state that optometry did laser procedures, and that is in the state that I'm sitting in right now, which is the state of Oklahoma. And I'd ask you, when was the first laser done by an optometrist in the state of Oklahoma? Anybody know what year the first laser procedure on an actual human eye was done by an optometrist? It was done in Oklahoma. Anybody know what year that is? Anybody? And actually was 1988, 36 years ago. The first laser procedure was done by optometry, by an optometrist here in the state of Oklahoma. And for a long time, Oklahoma was the only one. They were it. And when you're the only one, you're the anomaly. You are the crazy one. 49 are doing it this way, and 1 state is doing it this way, and that's Oklahoma. And they were on an island all by themselves throughout the late 80s, the 90s, the 2000s, and even into the 2010s. I remember, again, I'm not from Oklahoma. I'm a North Dakota boy, born and raised in North Dakota, did my schooling in Oregon, and I got down to Oklahoma in 2009, 2010, and I went, wow, that's one of the reasons I did my residency there, was because they were doing laser procedures, injections, and all that good stuff, and that's what my passion was. And they were the only state in 2009, 2010, and I remember going, wow, they're kind of the bullseye, the target is on Oklahoma optometry because they're trying to do lasers and surgery but we were the only one. We were on an island all by ourselves. But then there was two. And who was state number two? Anybody know who state number two is? State number two joined in 2011, and they matched Oklahoma's law. Now, what do I mean by that? In Oklahoma, we have an exclusionary law. It tells us what we can't do. We cannot do cataract surgery, and we cannot do LASIK, and we cannot do retinal detachment surgery, and we cannot do retina lasers. It tells us what we can't do, which is nice because then when something new comes out, like intracameral bimatoprost implants. Maybe you know them as Durista. When something new comes out, well, it's not on the exclusionary list, so therefore we can go ahead and do that. So we have an exclusionary law in Oklahoma, and the great state of Kentucky matched
Yep.
that in 2011. They were state number two. They have an exclusionary law as well. All right. Now we got two crazies. We got Oklahoma and we got Kentucky, and we got 48 that are doing it the other way. And we got these two crazies, Oklahoma and Kentucky. But then there was a third state. Who was state number three? They joined in 2014. They also have an exclusionary law. Anybody know who state number three was?
Is that Louisiana? I'm going to take a guess.
That is, there you go. The great state of Louisiana in June of 2014. And I remember, Greg, Joe, there were pictures of David Cockrell and Jim Sandifer and Chris Roten. And it was a big, and they were holding up three fingers going, this is a big deal. Now you can see there's more than just one. There's more than just two. You're seeing a mini trend over the course of the last 3 years, 2011, 2014. And now we've got two states that have joined in a span of about 3 years when there was only one for 20 plus years. So now you got Louisiana. We can now say, and then there were four. Who was state number four? Anybody know who state number four was?
I forget who 4 was. I know Alaska's in there.
State number four, I'll give you a clue, see if you can get it, has the best law in the country. It's not Oklahoma that has the best law. This state has the best law in the country. They have an as-taught law in this state. Who is it? It is Alaska. You mentioned it, Greg. It is Alaska, state number four in July of 17. What does an as-taught law mean? It means in the state of Alaska, if it is taught by an accredited optometry school, and regulations are developed by the optometry board, not by the legislature, by the optometry board, they can do that in the state of Alaska. They will never have to go back to the legislature again in the state of Alaska because they have an as-taught law. If it's taught in a school and the optometry board develops regulations, they can do that. So they were state number four. State number five, and then there were five. This state did it a unique way. They actually didn't pass a law in this state. They reread like their 1937 law and went, doesn't say we can't do it. We're going to start doing it in this state. And they started doing that in 2018. And that was the state of Indiana. They are doing laser procedures in Indiana for the last 6 years. State number six, Arkansas. State number six is Arkansas. State number seven is Mississippi. State number eight is Wyoming. State number nine is Wisconsin. Wisconsin did it the Indiana way. They didn't pass a law. They reread their law and said, you know what? It doesn't prohibit us from doing this, so we're going to start doing laser procedures. State number 10, Virginia in March of 2022. State number 11, Colorado. And the last state on this list, most recently added, is the state of South Dakota. As a North Dakota boy, it's close to home. I'm like, all right, upper Midwest, we're dominated by the SEC down here, all these SEC states. We've got South Dakota in there in March of 2024. These are your 12 laser states. If I would have asked at the beginning, how many states are allowing optometrists to do lasers? I asked that when I'm live, and some people say 4, some people say 3, some people say 6. We are now up to 12, right at a quarter of the states where optometrists can do laser procedures. My question for you is this: are you seeing a trend here? And the answer is no doubt about it, we are. There was one state for 20 plus years, and now in the span of 13 years, another 11 states have been added. Whatever state that you are in, do you want to be state 13 or 14 or 15, or do you want to be state 46, 47, 48? keep pushing, keep moving forward your scope of practice. You may not do the lasers, you may not do the YAG cap or the SLT or the PI, but the question that I would ask you is this: are you glad you can dilate the eyes? Are you glad that you can treat with eye drops? Are you glad that you can treat with oral medications? And the answer, I'm guessing, is a silly yes. Of course it is. Yeah, I can't imagine not dilating the eyes. It wasn't always that way. We were a dropless profession until the 1970s, and we had to fight for that right. And now we're so glad that we have that. We keep pushing forward, and optometry is well equipped to do these procedures. And I'm going to talk about SLT in depth. We're going to talk about laser trabeculoplasty. We're going to talk about newer forms of laser trabeculoplasty, where this is becoming more common and more common and more common. Did you know that it is now overwhelmingly been proven that SLT is a first-line treatment option in your patients with open-angle glaucomas? It wasn't always that way. We'll talk about that in just a second. But again, there's your 12 laser states. That's the list right there. Okay. So glaucoma, it is a puzzle. We truly add up the puzzle pieces in glaucoma, whether it's the diagnostic side on the left side here. You can see the visual field and the ERG and the optic nerve head appearance and corneal hysteresis and IOP and family history and OCT. You add up all these different pieces from a diagnostic perspective in glaucoma. Are we progressing? Are we not progressing? Because we have no one perfect test for glaucoma. We got to add up structure and function and different tests to say, is this glaucoma? Is it not? Are we progressing? Are we not? But then when we say, okay, we've got glaucoma, how are we going to treat this? We still got to kind of put the puzzle together with treatment as well. We've got so many wonderful medications, and we've got a wonderful laser called SLT, but we've got MIGs, we've got drug delivery devices, we've got all kinds of stuff for that we can mix and match for these patients. I didn't have the poll everywhere question. I'm going to pause here and get Joe and Greg's thoughts on this if they're still with me. If we have them type via the chat box. I don't think I can see the chat box, but
we'll follow that for you.
Okay. I would love everybody to type in the chat box or wherever it is, what % of your glaucoma patients are compliant with their glaucoma medications? I'd be curious. I usually poll the audience and ask that question. Is it 0%, 20%, 40%, 60%, 80%, or 100% of your patients? What % of your glaucoma patients are compliant with their glaucoma medications, their glaucoma eye drops? Greg, Joe, I'll throw that to you guys. Well, let's see what the answers come in from the chat box, but what would your answer be overall? What %?
Well,
I'm going to let the audience know to put it in the question, and Joe and I will see it. We don't have a chat box. They changed on us, Nate. But Joe, please go ahead. I just want the audience to do that as you chat.
I guess my question to you before I answer, Nate, is what do you define as compliant? How many accidents would you allow?
Yeah. I mean, then I think that's the ultimate question is, what do you define as compliance? Let's say they're getting in their medication.
Let's say 90% of the time.
I was going to say 90 to 95% of the time they get in their medication.
Okay, so if we have say compliance is 90%, I'm going to say probably in my practice it's 77%.
Okay, Greg.
I'm going to say 50%.
Okay. Is the audience, what's the audience saying? Is anybody typing in anything?
Yep. They're saying less than 50, 25, 40%. Someone couldn't find the chat box, but you found the question and answer, so you could type in your answer there. Someone has 60 to 70, 40, 75 to 80, 40, 75, probably 50, 50, 30, 25, 15, 25. And it's just going on and on and on.
So and you can see when I know there's very few 100%, I don't think there's any 100% compliance. When I ask that question and get 150 responses from the audience, on average, the number one answer is 60%. Optometry is generally feeling about 60% of their patients are compliant with meds and about 40% are not. So that's a lot of patients that are not compliant with their medications. And we know that patients feel the burden of this, the drop once a day. second drop twice a day, or whatever it is. And compliance leads to elevated intraocular pressure, leads to possible progression. We know that. There's no ifs, ands, or buts about it. So if we can ease the burden on patients, I know Greg and Joe know this very well and are believers in this, interventional glaucoma, taking some of the burden out of that patient with SLT, maybe it's MIGS, maybe it's drug delivery, whatever it is. But I think the days of drop 1 and then drop 2 and then drop 3 or more are over. We need to lessen the burden on these patients. We'll go through some of the data in just a second here.
Hey Nate, define that, because that's a new term that I know and Joe knows, but that's kind of a new term over the last, say, 18 months. Just define that interventional glaucoma.
Yeah, I define interventional glaucoma as we are intervening on the patient's behalf. They don't bear all of the burden, where the treatment is on them to do something that we are going to intervene to take some of that burden off of the patient, whether it's doing an SLT, whether it's having them have cataract surgery and a MIGS procedure, whether it's a drug delivery, whatever it is. But the doctor is intervening to help relieve some of the burden off of the patient, so it doesn't all rely on the patient. They have to do this. They have to do this. They have to do this. We're interventional glaucoma. We are intervening on their behalf to lessen the burden. That's how I define it. You define it any different?
No, that's it.
I don't define it any different. I don't define it any different. But when you talk about compliance, there's a subset that we have to understand is patients can be adherent to their regimen. They may not be skilled at instilling drops. See, we have a bias as doctors because from the very first day that we begin our training, we're putting drops in people's eyes. You go to the grocery store or the drugstore, and there's going to be shelves of eye drops just available to patients over the counter. We have a bias that everybody can put drops in, and the reality is they can't. And I know myself, when I have a new glaucoma patient that I will put on a medicine, I will actually demonstrate how to instill drops. It's a bias I think that we all have. They can be adherent. They can be reporting 90% compliance, but maybe the drop is not getting in their eye.
Speaking of just that, Joe, I always kick this SLT lecture off with this. Why SLT? Let's watch kind of a fun video here and give you a little kicks and giggles to start off our lecture. Here we go. That's a TV show. It's not even in our neck of the woods in terms of the ocular head, next to our eyeballs, but they've looked at this before in studies, and they've said just exactly what Joe said is, okay, Mrs. Jones, you say you're taking your drops, and I believe you. Show me how you're taking your drops. Watch this video. This one's hard to see because of the shadow of the fingers, but literally puts in like 10 drops. Here's my favorite one. Scrape through the eyelid, right on the eyelashes, test for yourself for neurotrophic keratitis, and then put the drops in. Even the best of intention patients likely are struggling getting their drops in. Our patients that have glaucoma, usually in their 60s, 70s, 80s, arthritis, poor dexterity. So even the best of intention patients may not be skilled enough, exactly as Joe said. He's so spot on in getting their medications in the eyes. Again, even the best of our medications, once a day, at night, lay in bed, put it in there. Some studies show, again, 18, 24 months in, we've got about a 30% compliance rate. There's no ifs, ands, or buts about it. We know that we battle compliance. You guys just answered that. And we need to address that. So
interesting, Nate. I wasn't sure what videos you were going to be showing, but a few years ago at the Optometric Glaucoma Society meeting, Bob Rich, who's a glaucoma surgeon specialist up in New York, showed us a video, a compliance video that he filmed on one of his patients, and he had a patient, an older woman who. She wanted to participate. She said, I'm good at this. This is perfect for me. I want to do it. And he filmed her, and it was like a blooper reel. 5 tries, and she still didn't get it. And she was getting so frustrated. It was comical almost, because she was, quote unquote, good at it.
She was certain that she was going to show you just how to do it.
Yep.
And struggled and struggled. Yep. So I think we would be naive if we thought that our patients, okay, they're remembering, but they're all doing it well. They're just not. They just don't have the capability in many of them to do that. Our traditional glaucoma paradigm, I think everybody on this call will agree, historically speaking, over the past 2, 3, 4 decades, this has been our treatment paradigm. It's meds are first. You exhaust the medications. Maybe that's 1 drop, maybe it's 2. Quite often it's 3 drops. And then we considered ALT. There's limitations of ALT. And then we'd go to surgery. It was meds, laser, and surgery. And I'm going to kind of finish with this of our paradigm has changed now. We've got 2 wonderful first-line options. SLT and medications in either order. You can go either way. Don't forget, we've got MIGS mixed in there. We've got drug delivery. And yes, we've got tubes and trabs at the end, things like that. But our paradigm is changing over the course of the last decade plus. So lots of reasons we use lasers. Again, I did 4 different laser procedures yesterday afternoon with our students and residents, and they are all a little bit different. The laser floater removal, YAG capsulotomy, maybe the most enjoyable, SLT and PI. PI is definitely the most rare, but I think this is the most needed of the 4 laser procedures for optometrists to do. I believe incredibly strongly, and I would fight to the death for every single one of you that you should be doing SLT if you so desire, because your patients struggle with glaucoma. SLT is a proven first-line treatment option. And here's my question for you. Who treats glaucoma first line in your state? I'll say that again. Who treats glaucoma first line in your state? And the answer is you do. Optometry does. And you are forced to go to eye drops. The first-line glaucoma provider should be able to offer the 2 first-line treatment options, whether it's drops or SLT. It is a travesty, in my opinion, that you cannot offer SLT. You almost can't screw up an SLT. I said almost. You certainly can. But it is an extremely flexible, forgiving laser, as we'll go into here in just a little bit. It would be a huge public health win if every single one of you could do SLT if you so desire to do that. And if you didn't, refer it to one of your optometric colleagues. They'd be happy to do the laser and send the patient back to you to manage. Optometry to optometry referrals, so very underutilized, and we need to consider that more often. So why do we need lasers? Again, lots of reasons. Is it compliance? Is it cost issues? Is it convenience? Is it they're progressing on their max meds? I encourage all of you, as you start doing SLT, or even when you're referring to SLT, write down, why am I doing this SLT? Why am I referring for this SLT? There's 2 main reasons why I do an SLT, 2 broad categories, and it's really only 2. I'm doing it to prevent the next med, or the first one, to prevent the next/first med, or to replace a current med. That is why you're doing SLT, to replace a current med. Mrs. Jones is on 1 drop and she's struggling. She hates being on it. Her eyes are red. She forgets. She's bad at putting it in. She's not progressing. She's on 1 drop and needs to be on 1 treatment, but she's struggling with that 1 drop. And we're doing SLT to replace a current med, to replace the one she's on. Let me flip it over to Mr. Jones. Mr. Jones is on 1 med, and yet the visual field is showing changes. The OCT is showing signs of progression. The pressure is not where the target pressure should be. He's on 1 medication, and we need to add a second because of progression. Now we're doing SLT to prevent the second med, to keep him only on 1 drop. Those are the 2 big broad reasons why we do SLT, to prevent a current, to replace a current med, or to prevent the next/first med. That's why we're doing SLT, and it's for a variety of different reasons here. So again, laser trabeculoplasty, again, different types, ALT, SLT. We'll talk about some of the newer ones called DSLT in just a little bit. They both likely increase aqueous outflow at the level of the trabecular meshwork, although there are different studies and theories on that. And they are by far the most common laser procedure done for open angle glaucoma. Again, ALT in the 90s, SLT is largely taken over at this point. By the way, Greg and Joe, let's see if you guys can get this one. I'm going to put you on the spot here. There's really only one reason, and one reason only, why anybody would do an ALT at this point instead of an SLT. What is that? Why would anybody do an ALT instead of an SLT?
Probably because they don't have an SLT to use.
Bingo. That's exact. They had a paper in 2006, and it was glaucoma special. This is, SLT was fairly new in 2006, only about 5 years old, and there was a paper of glaucoma specialists arguing ALT or SLT. And the ones that were arguing SLT said it was, it's easier to do, it's probably more gentle to the tissue, it's probably more repeatable than ALT. They didn't know it then. It's been proven now that certainly it is. So we're going to do an SLT. And the ones that argued ALT went, well, but the IOP reduction is about the same, and tends to work in about the same percentage of patients, 70 to 90%, depending on how you choose success. And why would I buy a new laser when I already have the green laser here that I use for retina and other things? That's really the only argument of why you would do an ALT instead of an SLT, is because you don't have an SLT laser available to you. So historically, second line treatment, as we said, drops are first. You maximize, you exhaust them, then you consider SLT. But some use this as primary treatment, and it now should be used as first line primary treatment. It's universally accepted because of this trial and many other trials in the late 80s and into the 90s. The glaucoma laser trial, one of the first big trials that directly compared ALT to the best topical medication at the time, which was beta blockers. And it found that ALT was generally just as good, if not even a little bit better than the best topical medication at the time. So ophthalmology took this, and rightfully so, and said, we have a laser that we can do in certain types of glaucoma. So I'm going to pause here for our first polling question. First polling question, Greg. Joe is up on the screen. Which of the following is not a type of glaucoma where a laser trabeculoplasty is usually indicated?
The polling question is open. For those that are having trouble finding it, on your right-hand side, you'll see Q&A. There's polls. You click on that, and you should be able to find the polling question. If you're on a phone, I'm not sure how it shows up. I can tell you on a device that you can see it says polls there. I see the responses rolling in. Nate, as your the polls rolling in, went to the Optometric Glaucoma Society meeting last year. In the last 2 years, it's been really neat to see them to kind of focus on two things. One was, and I always say it now in my pharmacology lectures, that if you have a glaucoma practice, you have an ocular surface practice, ocular surface disease practice, from all the BAK and all the inactive ingredients and the drops going in every day. So it was really neat to see them focus on that. And then kind of them focusing on the supplement side and the trabecular meshwork becoming sticky and oxidatively stressed, and even with the optic nerve. But really that focusing on the front, and then maybe that's why we want to do things like interventional to maybe even preserve that ocular surface. So as you go through here, I want the audience to kind of remember those points too.
Yep, absolutely. I didn't even mention that earlier. We talked about compliance and cost and convenience and quality of life. And how many of your glaucoma patients also have dry eye? As Greg just said, a good chunk of them, and we need to be mindful of that. So I actually have an email in my inbox right now that I just got from a doctor in Colorado like 2 hours ago, and he was asking about this right here. And it was a patient that has had significant trauma, has significant angle recession. The answer here, generally speaking, is which of the following is not an indication where type of glaucoma or laser trabeculoplasty is usually indicated. And the answer here would be we'd lean towards angle recession. Definitely indicated in POAG, indicated in low tension, pigment dispersion indicated as well. Generally speaking, if they've had significant trauma to the eye and where they have significant angle recession, your laser trabeculoplasty may not be indicated. It just may not be as successful when you've got damage to the angle there. Joe, Greg, you generally agree with that statement? Do you recommend laser trabeculoplasty and angle recession? I generally don't. Your thoughts?
No, I agree with you entirely, because the trauma that initiated it, it's not the fact the angle is open, but the inflammation, the trauma, the hyphema that probably came has now caused a degenerative scarring and sclerosis of the meshwork, which you just can't make it work again. A couple other places where I'd also would be hesitant would be steroid-induced glaucoma. I think the outflow difficulties are a little bit tough to overcome. Not to say it's contraindicated. I don't think that's going to work very well. Also, the inflammatory glaucomas, but that angle recession, that meshwork has scarred and sclerosed, and we're not going to jumpstart it. So I agree with it entirely.
So,
we got your polling question was 1% primary open angle glaucoma. Just one person responded. 17% went with low tension glaucoma. 22% went with your pigment dispersion glaucoma. And then 60% went with angle recession. And I agree that, it's probably dead is dead, and it's hard to kind of stimulate what you're kind of doing with these lasers. So the angle recession, it's probably created enough damage that you can't really make it work anymore.
So, here's your 5 big indications for laser trabeculoplasty. This is both ALT and SLT. And I've kind of listed these from strongest indication to still indicated, but you take it with a grain of salt. You maybe have some caveats, maybe a little bit of higher risk when you get to pigmentary and pseudoexfoliative glaucoma, which is just more fragile glaucomas anyway, especially pseudoexfoliative. So POAG and ocular hypertension, your top 2 indications. The angle is open, and you can't do a laser trabeculoplasty in its current format without having a good view of the trabecular meshwork on gonioscopy. So you have to have an open angle. So POAG, ocular hypertension are your top 2 indications. Why are they your 2 biggest indications? Well, this is important. Hear me on this. They've looked at before, how do you predict success with SLT? Wouldn't it be nice if I could say, all right, I knew that if I did an SLT on Joe's eye, it's going to lower his pressure by 35%. Okay. I'm going to do an SLT on Greg's eye, and it lowers his pressure 8%. Well, who am I more likely to do an SLT on, the 35% in Joe or the 8% in Greg? I'd much rather lower the pressure 35%, so I'm much more likely to do it in Joe. How do we predict success? Wouldn't it be nice if we can do that? And we don't have a fail-proof way. There's no perfect way. They've looked at age, they've looked at gender, they've looked at cataract status, they've looked at pigmentation in the TM, the number of medications they're on. They've looked at a lot of different factors of how do we predict success? And the strongest predictor of SLT success is pre-laser IOP. The higher the IOP, the more bang for your buck, the higher the percent reduction, which makes intuitive sense. So pre-laser IOP is your number 1 predictive factor for success. Number 2, and there's some controversy to this, there's some studies that refute this, but I do believe number 2 is probably the number of medications that your patient is on. So I'm going to pose a question to Joe and Greg to get their opinion on this of what percent pressure reduction do you expect from your first glaucoma drop? When you put a patient on their initial therapy, their primary therapy, probably going to be a prostaglandin analog. What percent pressure reduction do you expect? Joe, Greg, what's your number?
I'll go with 30% is what I would expect if it's a prostaglandin analog.
Okay.
And that would be a good number that I would, sometimes it's going to be over, sometimes it's going to be under, but let's say 30% PGA.
Generally speaking. Yep. Okay.
Generally speaking, I'm going to say probably about 27% pressure reduction, but I'm going to qualify it. If we're starting with a baseline of 18, I don't know, I'll get that far. If we're starting with a baseline of 42, I might be getting 50%.
Right. That pre-laser IOP, pre-treatment IOP, it matters. Okay. Similar question. Your patient is on 1 drop. Let's assume it's probably a prostaglandin, and you're about to put them on their second glaucoma eye drop. What do you expect for your percent IOP reduction from the second drop? Generally speaking,
10 to 15%.
Okay.
I'm probably looking about 22%.
22%. Okay. Now you're about to put them on a third drop. They're on 2, and you're going to put them on a third drop. What do you expect for your third glaucoma drop?
I'm thinking probably around 17%.
Okay. Greg?
Well, if I'm going to go there, I'm going to tell you a little clinical pearl that I would probably go with would probably be like a Tarsadil product because it's hard to lower a low IOP. So that would give me about 4 to 5 millimeters of mercury. So whatever that comes down to out of, say, maybe a 15. So I don't know, let's say 15 to 20% using that medication.
And that medication. But generally speaking, you guys saw the more medications we on board, their percentages went down and down and down. And generally speaking, that's true. I asked our glaucoma specialist that, what do you expect out of your third glaucoma medication? And he said 0 to 2 points is about what he expects for the third eye drop. It depends on which one you select, as Greg said. But my point is, if you're using SLT as a third drop replacement, you are going to expect less than as your primary therapy, where you have every right to expect 25 to 35% pressure reduction. So number of medications and the pre-laser IOP, those are your two biggest predictive factors for success in terms of SLT. If your patient has a pressure of 16 and they're on 2 glaucoma eye drops and you decide to do SLT, how much should you expect? And the answer is not much. You may get a point or 2 or 3 if you're lucky, but the biggest, it's going to blunt the up and down, the diurnal, as we'll talk about in just a little bit. But SLT works best earlier in the course of therapy. So POAG and ocular hypertension, those are your two strongest. Low tension glaucoma, that would be number 3. What's the biggest downside with low tension glaucoma? The biggest predictive factor for success, which is pre-laser IOP. The higher the IOP, the more bang for your buck. The lower the IOP, the less bang for your buck. And then pigment dispersion and pseudoexfoliative. They're indicated, but again, just be a little bit careful with those. We'll come back to that in just a second. Contraindications. Relatively speaking, advanced POAG, if they're a 0.95 cup and they have advanced severe, glaucoma, maybe they need something else, a tube, a trab. Have I done SLTs on advanced glaucoma patients? Yes. But, just consider that maybe they need something more than the SLT can give them. Narrow angles, that's going to be, cataract surgery or laser PI. And then your secondary types of glaucoma, like Joe mentioned, your inflammatories, your angle recessions, your neovasculars, your congenital. Couple of points I want to make on this, though. Those bottom, 2 of the bottom 3 bullets there. Prior laser trabeculoplasty that failed. That makes intuitive sense. If I do an SLT on Greg's eye today and it doesn't work, 6 weeks from now, 8 weeks from now to see the full effect, and his pressure hasn't moved at all, hasn't budged at all. Previously, and even when probably Greg took the course, which I believe was pre-COVID, I was saying, if it failed the first time, you probably shouldn't do it again. The leading glaucoma experts in ophthalmology, in our field, are now saying, you know what, just because it failed the first time, we'll go ahead and give it another shot. And that really doesn't have much predictive factor whether the second one's going to fail or succeed. So we are now willing to give them a second try or even a third try. And there's some evidence that says the second one gets a boost from the first one and may last longer than the first one. So I would scratch off on the contraindications this prior laser trabeculoplasty that failed, along with the under 40 years of age. That was definitely on the list for ALT. Let's not photocoagulate the meshwork when they're 35 years old or 40 years old. We're not doing that with SLT. So really, I do SLT in somebody if they're 85, 65, 45. It doesn't really make a difference in terms of age, and studies, generally speaking, support that as well. So very quickly, let's just talk about the traditional form of laser trabeculoplasty, ALT. This was the first one. It's argon laser or green laser. It is what they think a mechanical effect. If you watch my hands here, it's burn, photocoagulate, burn, and photocoagulate. When you get that contraction, when you get that scarring, it opens up the adjacent areas in between. Joe, Greg, tell me about the repeatability of ALT. Thumbs up or thumbs down on the repeatability of ALT, generally speaking?
Generally speaking, it's going to be a thumbs down. And I've never really been convinced that the contracture just merely opens up the pores, because aqueous processing is a dynamic phenomenon. It's not really passive, it's an active phenomenon. Now, if you keep photocoagulating that meshwork, you're going to have fewer areas that are viable to process aqueous. So that's not a very good option.
That's not a great option. No, repeatability is poor. They typically did 180 degrees or half the eye with ALT just so they could save the other 180 degrees and do it down the road whenever they needed to do it again, because they've got virgin meshwork there. They don't do 360 and ALT. They saved the other 180 degrees. So again, generally speaking, maybe mechanical exact mechanism effect is unknown. Here's your risks and complications. Your two main adverse events. Anytime you put laser energy in the eye, the two most common adverse events are IOP spike and inflammation. And every single one of you knows how to manage IOP spike and inflammation. We control this with brimonidine before a laser, brimonidine after a laser. We control this with a steroid postoperatively to help control the inflammation. Synechiae, that was more of a risk with ALT versus SLT. I've never seen a patient develop significant posterior or peripheral anterior synechiae from an SLT. It's just pretty rare with that. It's mainly IOP spike and inflammation. We'll talk more about this when we get to SLT here in just a little bit. So again, ALT has largely went by the wayside. The effects waned over time. It was done less and less and less over time because prostaglandins came about in the 90s, once a day, wonderful medications. But I'm going to leave it with this with ALT. Any questions, comments, thoughts? Joe, Greg, anything to add on our traditional laser trabeculoplasty? It's since really went by the wayside, argon laser trabeculoplasty. Anything to add?
I think you covered it pretty well. I don't think there's anything else I would throw in there.
Okay. On to
So
SLT.
Nate, I don't want to add anything with SLT, but I was just sitting here thinking, because I'm not the one lecturing here, but when I do a glaucoma lecture, I usually start off and I'll go through the MIGS and the SLT and so on and so forth, but ask the audience, is it an outflow disease or an inflow disease? And a lot of our colleagues believe that it's an inflow or a combination of inflow and outflow. But I believe a lot of the glaucoma experts would say that it's an outflow disease, a disease of the trabecular meshwork, getting that aqueous through the trabecular meshwork into Schlemm's canal, which the trabecular meshwork becomes sticky. It can start sticking to the Schlemm's canal, starts sticking into the collector channels, and then it has to get into the episcleral veins and eventually, to the cavernous sinus. So it's a disease of outflow. So I just kind of wanted to take a step back, go to the higher order here. That's why tonight you're going to focus so much on, there's so much during cataract surgery focusing on MIGS. You have the iStent inject, you have the Cahook dual blade, you got goniotomies. Obviously, we can't do that. But SLT, ALT, and that's why we're going to focus on it, because we're focusing on really the cause of this condition, that outflow. So you talked about one ALT, now you're going to move to SLT, but a lot of our colleagues think that it's still an inflow, overproduction, ciliary body. Everyone tonight, please remember this is more of an outflow disease, at least as we're thinking in 2024.
Absolutely. I 100% agree with that. And for a long time, we didn't have any big outflow drops that worked on that. It was uveal scleral outflow, but nothing really worked on trabecular meshwork outflow. Now we have drops that do that now. But SLT, one of the big benefits is working on outflow at the level mainly of the trabecular meshwork. So how does SLT work? It's not really new anymore. It's been around for close to 25 years now, over 20 years. And again, all the studies say the exact mechanism is unknown, but we think this is biologic. We think this is inflammatory. We think this is sublethal photostimulation, selective photothermolysis. There's all these different terms that you can use here. I like inflammatory. I tell patients when we do an SLT that, your own body's cells are going to do most of the work here. Your own body's immune system, your inflammatory cells are going to do most of the work here. So how does it work? Okay, let's go right to, before we get there, I put this right here. We're going to pause here again for our next polling question. Anytime laser energy is put into the eye, the two most commonly encountered side effects are what? Floaters and retinal detachment, inflammation and IOP spike, eye pain and permanent vision loss, or corneal ulcers and macular edema. So anytime laser energy goes into the eye, whether it's YAG cap, iridotomy, SLT, laser floater removal, when that goes into the eye, the two most commonly encountered side effects, what did we just mention? What are they?
The The answers are rolling in. The polling question is open. And I think you have done a pretty good job from what I see so far, but we only have about half the audience has replied. So,
and it might be the answer that I accidentally forgot to remove the bolding on. Maybe that B there, huh?
I was going to say, did you do that on purpose for a little
subtle
bit to
hint
help
there,
her?
huh, Greg, Joe? So,
Hope you don't do that with your students.
no. All right, we good to move on?
Yep, you got
Yep.
90% saying inflammation and IOP spike, and floaters and retinal detachment was 8%, and that was really it. So
Perfect. So how does SLT work? Stay with me on this one. There's something called the thermal relaxation time of melanin, a pigment. It takes the melanin in your body, takes the pigment in your patient's body a certain amount of time to absorb laser energy and cause a photocoagulative burn, a destruction burn, a killing of the tissue. You've all seen this before. You've all seen PRP. That's done with an argon laser, now a green laser, and there's others, there's yellows and all kinds of stuff, but it's a photocoagulative laser, generally speaking, and the pigment absorbs the laser energy and it causes a destructive burn. There is damage there. That's happens if the laser burn is longer than the thermal relaxation time of melanin, okay? If the laser burn is shorter than that, if it's shorter than that, the pigment, the melanin, doesn't have enough time to absorb the laser energy and cause a photocoagulation thermal burn, a lethal burn. The thermal relaxation time of melanin is about 1 microsecond, okay? 1 microsecond. So if a laser burn is longer than a microsecond, the pigment's going to have enough time to absorb the laser energy and cause destruction of the surrounding tissue. If the laser burn is shorter than that, then the pigment doesn't have enough time to absorb the laser energy and cause damage. Look at the pulse duration of SLT, 3 nanoseconds. 3 nanoseconds, which is shorter than a microsecond. So the pigment doesn't have enough time in the trabecular meshwork to absorb the laser energy and cause photocoagulation. That's why this is sublethal, not killing. It's sublethal photostimulation. Light is photostimulating those inflammatory cells. Selective photothermolysis. It's biologic, it's inflammatory. How I describe it to patients, again, I tell them, Mrs. Jones, we're going to use this very gentle laser. We're not even be able to tell anything was done, and it's going to kind of wake up your immune system just a little bit by the drain of the eye, and these cells are going to come up there and start cleaning out the cellular debris, start cleaning out the junk in the drain. If we clean out the junk in your kitchen sink, in your bathroom sink, the fluid's going to flow out better, isn't it? And the same thing happens here. That's how I explain it to patients. You know, your own body cells are going to do this very gently. You shouldn't feel anything likely during this procedure. That's how I explain it to patients. So why is this not destructive? Why is it not photocoagulating? It all goes back to the pulse duration, 3 nanoseconds. And by the way, you can't change that. On an SLT laser, it's fixed at 3 nanoseconds. There is no button or knob for pulse duration. That's it. You don't have to worry about it. It's 3 nanoseconds. You understand it because that's how an SLT works. It all comes down to the pulse duration. So there you go. That's why an SLT, and that's how an SLT works because of that pulse duration. So
Nate, would it be true that it would take 1,000 nanoseconds to make 1 microsecond? So that's not even close to even being close to that 1 microsecond.
Not even close. You are correct, sir. It's not even close for that. So, yep. So it's way shorter. So here's our third question. The mechanism of action by which SLT works is what? Which one of these? Is it biologic activation of macrophages and phagocytes? Is it those inflammatory cells? Is it mechanical damage? Does it burning a hole? Did we talk about any holes in the TM, or photodisruptive laser, which opens up areas of the TM to flow through? So which one of these? What did we just talk about? How does an SLT work? How does an SLT work? Think inflammation. Think these, I call them the trash collectors for patients, macrophages, phagocytes, all these, these inflammatory cells go up and clean up the trabecular meshwork. And Joe, Greg, I think it's all about how you phrase this to patients. We offer SLT first line for every patient now, and we make the decision together whether drops or laser works best for that particular patient. And if they ask, I'll give them my opinion on what I would do for my eyes. And we make the decision together. And if you phrase it this way, well, Mrs. Jones, we can shoot a laser in your eye that we don't often do. We didn't do this a lot in the past, but we're starting to do more of this now. And, it may work, it may not, but, let's just shoot this laser in your eye. They may not go for that, versus very gentle laser. I was lecturing with Paul Singh. I bet both of you know who Paul Singh is, world-renowned ophthalmologist out of Racine, Wisconsin. We were doing a webinar together. And kid you not, Paul goes, this is how he phrases it to patients. We're going to do something called selective light therapy. And this very, very gentle light, doesn't even call it a laser, this very gentle light, we're going to use it. It's going to massage and tickle the drain of the eye to enhance and rejuvenate the flow of fluid. Well, now we're massaging and enhancing and rejuvenating and massaging. Sign me up for that, huh? Let's go. What do you guys think? It's pretty funny.
Yeah, I mean, I think it's in the delivery of it. And yeah, I mean, if you present it the first way, you're going to have, patients not go for it. So I agree that since it's been around long enough, we can probably go and seen a lot of positive effects from it and soften and not see the side effects that we would expect, but that we saw within ALT for us guys that have been around for ALTs.
Yep. So remember the answer here is A, it's biologic macrophages, phagocytes, inflammation,
You had 71% go with A, about 20% went with D.
All right, there you go. Photodisruptive laser, that's a YAG laser. YAG lasers are photodisruptive, so not that one there. All right, moving on. Let's look at the data. I think this is important. You got to have the data on this. So here's your patient. This is a 60-year-old male. Men, listen to me. We love to go to the doctor, don't we, Joe? Don't we, Greg? But men just love going to the doctor. I'm obviously being sarcastic there. 60-year-old male, drug into the clinic by his wife. He's got a family history of glaucoma. Your mom's went blind from glaucoma. You need to have an eye exam. And you take a look at the nerve. You take a look at the visual field. Pressures were in the mid-20s. This patient, certainly you're pretty suspicious this patient has glaucoma. Let's say you say it's glaucoma and you decide to treat first line. What would you use for this patient? So here's one of the first big trials, if not the first big trial in the United States to directly compare SLT to prostaglandins first line therapy. First line therapy. Treatment naive. They've not been on any other treatment. Let's do SLT first line or prostaglandins first line. Of note, this was the study that took us to 360 degrees when we did SLTs. When I did my residency in 2009, 2010, we were doing 180 degree SLTs. Why were we doing 180 degree SLTs? Because we did 180 degree ALTs before then. ALT was done 180. When the new version came out, well, we did 180 degree ALTs. We might as well do 180 degree SLTs. And it took about a decade to figure out, it's gentler on the tissue, more repeatable. We can probably do more degrees with the SLT. And this was the study in 2012 out of Will's eye that went to 100 applications over 360 degrees of the trabecular meshwork. This was the study that took us to 360 degrees. Today in 2024, when we do SLT in POAG, ocular hypertension, and low tension, we do 360 degree SLTs. We do 180 degrees or less in pigmentary and pseudoexfoliative glaucoma. But in most glaucomas, POAG, ocular hypertension, low tension, we are doing 360 degrees. This was one of the first studies to guide us that way. So what did they do? Half the patients went down the prostaglandin arm, first line. Half the patients went down SLT, 360, first line. And let's see these patients every 2 months. Let's set target pressures. And if you don't meet target pressure, those that got drops were getting more drops. Those that got laser were getting more laser. That was the number of treatment steps. Look at that secondary outcome. Number of treatment steps needed over 1 year of this study. So there's your different groups, not a huge N number, okay? Not a huge N number in this study. And the results were there. 28% pressure reduction in that prostaglandin group, 26% pressure reduction in the SLT group. That did not reach statistical significance. Therefore, the results were the same. They were equal. Again, 26 to 28% pressure reduction for both groups. How about the number of treatment steps? 11% of patients in the SLT arm needed more SLT during the study. 27% of patients in the prostaglandin arm needed more medications during the study. Why do you think more patients needed more treatment in the med arm? Well, they weren't meeting target pressure. Why do you think they weren't meeting target pressure? Compliance. You got it. And when you help to ease the burden of compliance, when you intervene on the patient's behalf, less patients were needing more therapy. So this was their ultimate conclusion in 2012. IOP reduction was similar. More treatment was needed in the med group, although that wasn't statistically significant either. These results support the option of SLT as a safe and effective initial therapy, primary therapy in open-angle glaucoma or ocular hypertension. That was 12 years ago out of Will's eye. SLT is primary therapy. Study out of Israel. Again, 40 eyes. SLT is effective and safe as a primary treatment option in ocular hypertension and open-angle glaucoma. Notice this 18-month study, 30% drop, and it held for the 18 months of the study. Here's the big one, and I'm sure everybody on this call has heard of the LIGHT trial. SLT versus eye drops, first-line treatment, ocular hypertension and glaucoma, the big LIGHT trial that was released in the spring of 2019. And it really helped to answer a couple of the criticisms of this study, the SLT med study that we just covered, that small N number, only 1-year trial. Let's now do a big N number, big study, multi-center, observer masked, randomized control trial, treatment naive patients, first-line therapy, prostaglandins first line, SLT first line. Let's see which one is better. Okay. They looked at quality of life at 3 years. They looked at cost. They looked at cost effectiveness, clinical effectiveness, safety. They looked at a lot of things in this groundbreaking LIGHT trial. This was really a revolutionary LIGHT trial. Their conclusions: no difference in quality of life at 3 years. No difference between drops and SLT at 3 years. I'm going to come back to that in just a little bit. Notice, though, which one is more cost effective? Does insurance have any issues with covering SLT first-line therapy? And the answer is no, they do not. They said in this study, 97% probability of SLT as a first treatment being more cost-effective. You can see the amount of time at target IOP, SLT, and meds, and 75 to 80% of SLT patients were drop-free at 3 years. Okay, so this was their ultimate conclusion. SLT, not could be, should be offered as a first-line treatment, open-angle glaucoma and ocular hypertension. Wait for these words: supporting a change in clinical practice. Some big words there. SLT, not could be, should be offered. First-line therapy, supporting a change in how we do things. Change is easy, isn't it? Change is just easy all the time. No, it's hard for all of us. Supporting a change in clinical practice. Gone are the days of drop 1, drop 2, drop 3, and drop 4, interventional glaucoma as we defined earlier. Let's dive into some of the numbers, into this 3-year LIGHT trial. 3-year, multi-center, randomized, big N numbers. Not 40 patients going down each arm, 325 patients-ish going down each arm. 5 times less adverse events, excuse me, in the SLT arm compared to the drop arm. And 75 to 80% of patients drop-free at 3 years. That's the number that I told patients from 2019 to 2022. When we were making that decision, drops, SLT, first-line treatment, which one is, we're going to make the decision together as doctor and patient. Mrs. Jones, we got 2 wonderful first-line options. If we decide to do the SLT, this very gentle laser, there's a 75% to 80% chance that you will be drop-free for the next 3 years. The biggest downside to SLT is what? It doesn't last forever. It's going to wear off very, very likely. But what's the good news about SLT that we didn't have with ALT? We can do this again. It is repeatable, and more data is coming out on that. So it likely will wear off. This is not going to last the rest of your life, but we can repeat this. We can do this again. 75 to 80% of patients drop free at 3 years. Last point. How likely is your patient that was just started on treatment today for glaucoma going to need surgical intervention, invasive surgery, tube or a trab in the next 3 years? How likely is your patient you diagnosed today? The answer is not likely. They were just diagnosed with glaucoma. And notice it's a very low percentage, 11 out of 323. I say again, 11 out of 323. That's 2.3% of patients in the drop arm needed invasive surgery in the first 3 years. Why do you think 2.3% needed invasive surgery in the first 3 years? What's the answer? Compliance. Compliance is the answer. And when you eliminate compliance, a big fat goose egg in terms of SLT needing surgical intervention. So that was the summary results for the 3-year light trial. This study just kept going. All right, now September of 2022. Remember, the original 3-year data was in 2019. Now we're in 2022, and we've got the 6-year data. Now, going back to that quality of life, I'm going to go back here. Quality of life at 3 years. There was no significant difference in quality of life at 3 years. But I think everybody on this call would agree. If we compare drops and SLT, first week, probably no quality of life difference. First year, maybe no quality of life difference. Even here at 3 years, no quality of life difference. But the longer that you go, as the days turn to weeks, turn to months, turn to years, turn to decades, the likelihood of, in terms of quality of life, is going to go down for the drops because of that burden. They stink at putting the drops in, as we talked earlier. Quality of life has got to tip in the favor of SLT the longer that this study goes. And that's exactly what happened here, is at 6 years. Again, it was still close. It was still close. But SLT had better scores in the glaucoma symptom score, quality of life. So a slight win, quality of life for SLT at 6 years. Here's the number I tell patients now. Mrs. Jones, if we decide to do SLT first line, there's about a 70% chance that you will be drop-free 6 years from now. 70% chance you will be drop-free 6 years from now. That's a big deal. 70% chance you'll be drop-free 6 years from now. Now, don't let me fool you. That may not just be one SLT, okay? So if there's 100 of you on the call, and we do a first-line SLT in every single one of you, what percent, how many of the 100 will be drop-free 6 years from now? The answer is 70. Okay, 70 out of the 100, based on this data, will be drop-free 6 years from now. Okay, of those 70 out of 100, of the 70, 62% needed one SLT to be drop-free, 32% needed 2 SLTs to be drop-free, and 6% needed 3 SLTs to be drop-free. 62%, one SLT, one. 32% needed 2 SLTs to be drop-free over 6 years, and 6% needed 3 SLTs to be drop-free over 6 years. So 43 of the 100 patients had 1 SLT and were drop-free with 1 SLT and 1 SLT only at 6 years. That's what is 43 out of 100? That is 62% of 70. Okay, so just doing the math, go back to the main number, 70% of patients drop-free at 6 years. To me, that's not the most impressive number. The most impressive number is this next one. And I'd ask you guys, what's the ultimate goal in glaucoma? What's the ultimate job in glaucoma? To prevent progression, leading to blindness, to prevent progression. More eyes in the drop arm exhibited disease progression. 27% versus 19.5%. You were more likely to progress if you got an eye drop in this study versus if you got SLT. And why is that the case? And we all know the answer. It's compliance. Absolutely is compliance. More eyes in the drop arm exhibited disease progression over a 6-year period. Oh, by the way, a trab was required in more eyes in the drop arm versus the SLT arm. More cataract surgery was seen in the drop arm compared to the SLT arm. There was no serious laser-related adverse events, and that was the ultimate conclusion in this study. SLT is a safe treatment, providing better long-term disease control than initial drop therapy with reduced need for incisional glaucoma and cataract surgery over 6 years. So I'm going to pause here with our fourth question here about the SLT med study. Remember, this is the one about Will's eye. that was released about 12 years ago. And it, remember, looked at prostaglandins and SLT. What did it find in terms of IOP reduction and number of treatment steps? So while they're answering this, Joe, Greg, your thoughts on the data, the light trial that we just went through.
Yeah, I mean, I saw that first, I think at OGS in 2019. And I think real quickly, that's whenever I started. I wish I could do SLT myself as an optometrist that does a lot of glaucoma in Pennsylvania. But I do have an ophthalmologist that does come in once a month, which, does open me up a little bit better access. And, we do offer it as first line. We do couch it as gentle and, like you said, it's how you want to promote it. And we've seen very similar results. I'm in a very white population where I am. And, it's nice watching these ocular surfaces heal or not get damaged whenever you offer it as a first line of defense. 3 to 5 years out, they're doing well. I'm starting to get, now that we're 2019 that it came out, we're getting into that 5 years, and we're starting to do a little repeat on a few people, but not a repeat on everyone. So what a nice tool in the tool belt for the treatment of glaucoma.
So remember SLT med study, these showed that they were statistically equal in terms of IOP reduction and number of treatment steps. That was the SLT med study 12 years ago. So the answer is C. In this
64% of the audience went with that. So that's good.
Good. Okay.
33% went with A.
Well, and I would argue SLT is, probably you could make an argument, at least clinically, probably superior in the light trial when you're more likely to progress in the drop arm versus the SLT. I remember, again, I was asking about the SLT med study in that question there, but there's no ifs, ands, or buts about it. SLT is equivalent at least to drops for first line therapy. So that's what the data says now in 2024 when you look at all of that. So what are the risks? It's a very, very safe laser. I do say this tongue in cheek. I say this jokingly, but you almost can't screw up an SLT. You can, and I'll talk about ways that you can do that, but this is, in my opinion, clinically, and I do a lot of lasers, the safest laser that we do between iridotomy, laser flow removal, capsulotomy, SLT. This is the safest laser we do. You almost can't screw this up. I definitely say this jokingly, Greg, Joe, and I say this way, I can't see all the docs there, but I always say when I'm lecturing live, where do you aim? Somewhere between the top of their head and their belt buckle. Just kind of throw the energy somewhere in this area. Again, I say that jokingly, but I'm going to come back to that near the end of this lecture. How many of you have heard of transscleral SLT, otherwise known as direct SLT or DSLT? Transscleral. No lens on the eye doing SLT. We're going to finish with that in about 20 minutes from now. So again, it's very flexible, very forgiving in terms of the SLT. Now, can you overtreat and battle IOP spikes? You certainly can. If you're going to battle one thing with SLT, it's going to be IOP spikes elevation, especially in heavily pigmented angles. Be cautious in pigmentary glaucoma, pigment dispersion, pseudoexfoliation. But IOP spike is number one. Inflammation. You think you're going to create a little inflammation with an SLT? And the answer is yes. That's how it works. It's inflammatory, it's biologic, it's sublethal. Remember those macrophages and phagocytes and creating a little bit of inflammation. So you can create some inflammation there. Stromal haze and edema. Yeah, that's rare. It can happen. There's documented case reports. I've had a case or two where they developed stromal haze or edema in the day or 2 or 3 after SLT. You treat it with a steroid, goes away nicely. Peripheral anterior synechiae, very rare, less likely with a SLT compared to ALT. I've actually never had a case of peripheral anterior synechiae developing from SLT. So preoperatively, what do we put in before an SLT? It's never wrong, in my opinion, to put in brimonidine. Put in your brimonidine or your aproclonidine. Put that in 15 minutes before, 10 minutes before, 20 minutes before. Put it in before in office and put it in after in office. 1 or 2 drops before in office, 1 or 2 drops after in office. It's never wrong to do that. Pilocarpine. I typically don't put in pilocarpine unless I need to see just a little bit more of the angle. You're going to do pre-op gonioscopy. And when you do pre-op gonioscopy, you're going to check to Can I see the trabecular meshwork and the entirety of the trabecular meshwork and how much pigment is in the trabecular meshwork? If you look at Dugonio and you go, man, I would like to see a little bit more of the TM. I can see most of it, but maybe not all of it. You could put in pilocarpine to kind of shrink the iris and do your SLT procedure. I typically don't do that in about 95% of patients, but it's optional. You certainly could do that. Laser settings. Another reason this is one of the easiest lasers that we do, most straightforward lasers that we do, is you don't have a lot of settings to change. When you sit down at an SLT laser, there is one laser variable and one laser variable only that you can change, and that's the energy. Spot size is fixed. Can't change it. It's 400 microns. Can't change it. There's no button. Duration, 3 nanoseconds. We already covered that. The pulse duration of SLT is 3 nanoseconds. You cannot change that. It's fixed. There's no button. There's no offset like a YAG laser where you're worried about pitting of the IOL. There's no offset. One variable that you can change, and that is the energy. And the typical starting energy, I want you to remember this number. It's going to be maybe a question coming up here. 0.8 to 1 millijoules. 0.8 to 1 millijoules is the most common starting energy for SLT. That does depend on pigment. The more pigment that they have in the trabecular meshwork, you tend to lower your energy. The less pigment in the trabecular meshwork, you elevate your energy. So it's based on pigmentation. But typically 0.8 to 1 millijoule. I want you to remember that number because we're also going to talk about near the end low energy annual SLT. Low energy annual SLT, which is where some of the studies are now going for SLT. I think our protocol is going to change as we move forward. We'll talk about the COAST trial, among others, in just a second here. But 0.8 to 1 millijoule, our typical protocol. If I had to give you my number, I start on 0.8 millijoules. 0.8 millijoules is my typical starting energy. That's the only setting that we can adjust. Patient's comfortable. You're comfortable. All right, we're right behind the laser now. We put our laser lens on the eye. We've got our lens. We typically have used a Latina lens. Dr. Mark Latina, given much of the credit for inventing SLT and developed the Latina lens. This is a single mirror lens. What's the downside of a single mirror gonio lens, or in this case, a single mirror laser lens? Rotate, 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 rotate. You got to rotate this a lot, but it's a great lens. Wonderful view, nice big mirror. This is what I used from 2009 when I started doing lasers till 2018. 2009 to 2018, I used the Latina lens. I started with my mirror at 9 o'clock, and I went shot, 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 right up the mirror. And then we rotated, and then shot, 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 and then you rotate. We just worked our way around. Awesome. Took about, on average, depending on the patient, about 3 to 6 minutes per eye, 3 to 5 minutes per eye when doing a 360-degree SLT with the Latina lens. And I loved it. And then this lens came out. And this is the Rapid SLT lens, and this is distributed by Volk. This was actually invented by an optometrist, Dr. John McCall. Maybe some of you know Dr. John McCall, optometrist in Texas, also practices in Louisiana. He said, you know what? There's got to be a better way to do this than this rotate, 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 rotate business. Let's develop a 4-mirror lens. And this is the Rapid SLT lens, and it has 4 mirrors. How many times do we have to rotate it now? Once. And when I do this, I start at the top mirror. Okay, and this is a little bit cockeyed, but this is the top mirror here. And why do I start at the top mirror? Because the top mirror is the inferior angle. I promise you, it is the easiest mirror to do. The inferior half is easier to do than the superior half. So 8 mirrors. I'm going to do the top mirror. Boom, boom, go across. And then I do the right mirror, the bottom mirror, and then the left mirror. And then it's time to what? Rotate. And we rotate this one time. Instead of rotating it 8 to 12 times with this, we rotate it one time with the Rapid lens. And then you do the obliques. Top left, top right, and bottom left. 100 shots over 8 mirrors. We just talked 8 mirrors, 100 shots, about 12 to 13 shots, 11 to 14 shots per mirror. Awesome. I sat through a 4th-year optometry student doing her first SLT yesterday. She did an awesome job, 360 degrees in both eyes. and she took 100 shots in the right eye and 99 shots in the left eye, and it was perfect. Awesome. Did a great job. 100 shots over 8 mirrors, roughly 12 to 13 shots. This is taking our SLT times. Hear me on this. Remember this. About 3 to 6 minutes per eye. 2 to 4 minutes per eye. So it's definitely cut the SLT times down significantly, having those 4 mirrors. But I want you to remember those times. Somewhere between 2 and 6 minutes, depending on the patient, what lens you're using. Somewhere between 2 and 6 minutes. We'll come back to that in just a little bit. This is Chris Roten's slide. You may know my good friend, Dr. Chris Roten in Louisiana. This is his slide. Notice what he says in the bottom right. Rapid lens maybe cuts the SLT time in half. Cuts it in half because of those 4 mirrors there. All right. Spot size comparison, ALT and SLT. ALT is in green, SLT is in red. You're going to have one great big beam. One great big beam. You don't have 2 beams like a YAG laser that you bring together. One great big beam. You just cover the trabecular meshwork. Just cover the trabecular meshwork and you move along that angle that you're working in. So there's your spot size comparison. Again, big spot size, just cover the TM. And again, there's truly, I'm not joking on this. There's literature out there that says, it doesn't really matter where you hit. Not so much matter whether you hit just the TM, you overlap to the scleral spur, you hit this Schwalbe's line, you got to, into the ciliary body. And I don't know if that matters. The energy, 0.8, 0.5, 1.2, whatever, just kind of somewhere in the area. There's actually studies by Nate Radcliffe and Mark Latina and Gus Gazzard, who's the lead author on the Light trial, that went, it doesn't really matter where it's at. We're just creating this inflammatory response. Now, there's a caveat that you got to know what you're doing. You don't want to overtreat, especially in a heavily pigmented angle, but there's a lot of flexibility and forgiveness when it comes to SLT. You just kind of put it in the area, and that fits when we talk about direct SLT in just a little bit. Adjust your energy as needed. Again, I start around 0.8 millijoules, 0.8, and you want the lowest energy that produces bubbles about half the time. The lowest energy that produces bubbles about half the time. That's our typical endpoint as of right now. 360 degrees, that's what we treat unless they have significant pigment in the TM. And you do about, again, 100 shots. 50 shots for half the eye or 100 shots all the way around. Again, 12 to 13 shots in your 8 mirrors. Top mirror, right mirror, bottom mirror, left mirror, top left, top right, and bottom left there. So let's watch some videos. Let's watch some videos here for the next 10 minutes or so. Joe, Greg, it's not an incredibly exciting procedure to watch. What are the skills to do an SLT? What are you really watching here? What skills do you need to do an SLT?
Gonio skills, gonioscopy.
Gonioscopy. If you are comfortable with a gonio lens in your hand, you are going to be comfortable in SLT. You want to get good at lasers, get comfortable with a gonio lens on the eye. Get comfortable in the angle for SLT. This is all about slit lamp and gonioscopy. It is slit lamp and gonioscopy. And I always pause it right here, and you need to take a look. Iris, 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 iris. We got a little ciliary body band right here. There's your ciliary body band. And we got, what's that little white line right there? There's the scleral spur, posterior pigmented trabecular meshwork, anterior less pigmented trabecular meshwork, and lastly, we've got Schwalbe's line right in here. One big beam. There's your beam. One big beam, and you just cover the trabecular meshwork. Understand your angle. You do a lot of lasers, you're going to get good at gonio. You do a lot of gonio, you're going to get good at lasers.
Yeah, Nate, I remember whenever I took the course, you said, you do a lot of gonio. I don't know if you remember or not. You were like, you do a lot of gonio. And one of the pearls, I wanted to get good at gonio, and I worked at an OD-MD practice doing cataract post-op. So one of the pearls I like to give is that, when I used to do those, 15 to 30 post-ops a day on the 1 week, I didn't do it on the 1 month. The 1 week and 1 month, I would do gonio in all these patients. The one, they didn't know what post-op care took, but I knew the angle would be wide open because they were pseudophakic. So I would encourage, anyone that's thinking about doing this, it is a gonioscopy skill, just practice your gonio. You can do it on glaucoma patients, do it on your cataract patients. Actually, the one time I did it, I found a lens particle in there, a lens part of the cortex in there, and they were able to get that out before it created any inflammation. Just practice gonio would be my advice.
Yep. It is truly gonioscopy. You started training for laser procedures your first year of optometry school, when you were training on optics, when you were starting to learn slit lamp late in your first year, early in your second year, you were training for laser procedures. Our second years, it's the fall of their second year, start of their second year, and they are learning gonioscopy right now. They are training for laser procedures. You may not have realized it. I didn't realize it then, but your laser training started then. And we're about
Hey, there's a bubble popping up every so often. Can you point that out on with your pointer?
Yep. And you can see it. I'll pause it here. If you go back, see all these little champagne bubbles. That's what they call them, champagne or cavitation bubbles. And again, you want to see those about half of the shots. That you're definitely, you see more. Look at all those little bubbles, and they dissipate, but you can see all those little bubbles, those champagne bubbles, cavitation bubbles. The more pigment they have, the more likely you're going to see those champagne bubbles or cavitation bubbles. Okay, I'll go back to where we were. Over here, you can see some bubbles. Yep, you can see them kind of floating up there. You know, the more pigment they have, you're definitely going to see more champagne bubbles. The less pigment they have, the less champagne bubbles. Again, we used to want them like every shot. We'd be right on the kind of threshold of the energy that produces them every shot. We have since lowered that threshold, and it's kind of like every other shot, half the shots. Again, over time, we've kind of lowered our energy, and I think we're going to about do it again when the Coast trial comes out of low energy annual SLT. Again, we'll finish that in about 15 minutes from now. The low energy annual SLT. So, yeah, just moving along here. I'm going to move on to the next video. So again, this is the Latina lens. This video is from about a decade ago. I show because you can see the champagne bubbles really easily, you know, rotate, 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 rotate. And then we had this one come out. This is the rapid SLT lens. And I was hesitant. I was like, I don't know, you know, the mirrors are smaller. I don't know if my view is as good. Well, really, Joe, Greg, why was I hesitant to switch to the rapid lens after using the Latina lens for 10 years? Because change is hard, you know.
That's right.
I thought to myself, I've used the Latina lens and that's all I've needed. Why do I need to switch anything now? You know, I mean, change is hard, you know, and I'm really, I mean, it really was the lab during the laser course, where I saw all of you guys that were taking the laser course pick up SLT so much more quickly when you don't have to rotate, put this on the eye, you do your 4 mirrors, you rotate it once, and then you're good after that.
Hey, Nate, I'm going to see if they can see this on as I'm speaking here. I'm going to hold this little bottle up, pretend it's your gonio lens. If you're using like a Sussman lens, I'm going to encourage most people to hold it with their thumb and their middle finger. I'm going to pretend this is the eye here, and then you can put your finger on the lens and it will help rotate. When I learned that technique, it's kind of like an E technique, if you want to call that, where you're holding the lens like a Sussman lens. If you're doing that with gonioscopy, this would be the eye, and then you can just spin that lens all day long, taking your finger off so you can see the view, and that fingerprint is not going to mess up your view because it's outside the optic. So I would encourage people to kind of hold it with the thumb and middle finger, put the pointer finger on the lens. You're not going to push too hard, and you can rotate that all day long if you want to practice gonioscopy, or if you're going to use like a single mirror lens.
Nice open angle, decent amount of pigmentation. You can see the champagne or cavitation bubbles. You know, simple, straightforward. Okay. You see an angle like this. I always show this video last. Heavily pigmented angle. Is this indicated? Yes, it is. There's 3 things that we change in pigmentary glaucoma, pigment dispersion. 3 things. Number 1, we turn the energy down. From 0.8 to 1 millijoules, we may be at, 0.4 or 0.5. Turn your energy down. You are asking for an IOP spike. You are asking for an IOP spike if you treat these heavily pigmented angles with normal energy, okay? So make sure you turn your energy down. Remember, this is selective for pigment, SLT, selective laser trabeculoplasty. It's selective for pigment. And the more pigment they have, the more inflammation that's going to be created, and you don't want to create too much inflammation. So turn your energy down. We do less degrees instead of 360 degrees, maybe 180 degrees, and I'm more likely to put them on a steroid in the post-operative period, just to titrate that right amount of inflammation. You want some inflammation, but you don't want too much inflammation. You want some inflammation, but you don't want too much inflammation. So turn your energy down, less degrees, and you put them on a steroid. So our last question, question number 5, the typical starting energy when performing an SLT, 200 milliwatts, 1200 milliwatts, 0.8 millijoules, or 1.5 millijoules. You're about to do your first SLT. What are you going to dial your energy into?
So Nate, on those really heavily pigmented, can you space them out further and treat 360? So maybe, like you said, per mirror, like say 12 spots, do 6, or are you just going to treat tight and go 180?
So we don't have any studies or literature that guides us one way or the other. What I do is I just make it quicker, more efficient. I'm going to put 12 shots in the top mirror, the right mirror, the bottom mirror, and the left mirror. When I do 180, then I don't have to rotate. 0 rotations. That's what I would do. And I'll note that in the chart. And then next time we do 180, I'll do the obliques. So that's how I do it. But it certainly would not be wrong at all if you said, you know what, I'm going to do 6 to 7 shots in the 8 mirrors, and I'm fine rotating with the ones. Totally fine. Totally.
Your audience was paying attention. They've got 88% did 0.8 millijoules.
Cool. Got about 15 minutes left. So we'll finish strong here. Post-op, brimonidine, check their pressure. Most IOP spikes start about 30 minutes an hour, up to 5 hours after the procedure. And then post-operatively, we typically put them on topical NSAID as needed, nothing, or a topical steroid. The SALT trial, the steroids after laser trabeculoplasty trial, said, steroids are probably not wrong. I was trained that steroids are wrong. Remember Leo Scorin? I followed him for 4 months, and he did a bunch of SLTs, and he always said, I'm going to use nothing post-operatively. I remember him telling patients, if your eyes are red and sore and achy and light sensitive after this laser, good. I want them red and sore and achy and light sensitive. It means there's some inflammation going on, the intended inflammation. That maybe is a little bit harsh, but nothing is okay. Topical NSAIDs as needed, or a topical steroid, probably not wrong as well. So 1 to 2 week post-op, 6 week post-op, takes 6 weeks to see the full effect of laser trabeculoplasty. Biggest thing is it wanes over time, and this is repeatable, as we'll go into in just a second. So how do you predict success? Pre-laser IOP, as we said, the number of medications they're on. Are they on a prostaglandin? I don't have time to get into this. There are some studies that say prostaglandin success predicts SLT success. Prostaglandin failure predicts SLT failure. And there's some studies that say maybe you don't mix and match a prostaglandin and SLT. Clinically, I don't agree with that, but they do work somewhat similarly. They're both inflammatory. They both work on outflow, maybe different outflow mechanisms, but they're both inflammatory and work on outflow. There are some studies that say an SLT pairs best with a what? An aqueous suppressant. You've got the outflow from the SLT. We're hitting the inflammatory outflow. Let's do an aqueous suppressant if we have to pair it with a drop. I think maybe in theory that makes some sense. Clinically, we have patients on SLT and prostaglandins all the time. So long-term, it's going to wear off over time. It's not going to last forever. People always ask me, Nate, how long do you expect SLT to work? And the serious but a little bit joking answer is somewhere between 1 and 10 years. That doesn't give you any help, but like 1 to 10 years, narrow that down a bit. I expect my SLTs to last somewhere between roughly 3 and 7 years, 4 to 7 years. So remember the light trial. 43 out of 100 patients, 43% of patients had one SLT and it lasted 6 years. So 40, remember, that was 62% of the 70. 70% of patients dropped free at 6 years. Of those, 62% of the 70 needed just one SLT. That's 43 of the 100. So yeah, there's a decent percent of patients that should get 6 years out of this. Some are 5, some are 7, some are 4, some are 3. Somewhere between 3 to 7, 4 to 7 years is the middle of the bell curve for most patients. Now, some may only get 12 months. Some may only get 18 months. Some may only get 2 years. Am I disappointed a little bit? Yes. The middle of my bell curve is, again, 3 to 7 years, 4 to 7 years. Some are longer, some are shorter. And what did the Light trial say? More data coming out of the Light trial here. And they looked at patients requiring retreatment within 18 months. All right, so these are the ones you're a little bit disappointed in. They didn't last 4 years, 6 years, 7 years. They lasted 18 months. They required retreatment. Okay, retreatment was triggered by failure to hit the individual's target pressure. 115 eyes met those criteria. They looked at survival estimates, and they found that the repeat SLT, the red line, was lasting longer than the initial SLT. So after repeat SLT, the cumulative effect of the initial and the repeat may provide an equivalent, possibly longer duration of clinical benefit than the initial SLT. Repeat SLT is safe with minimal laser-related side effects. This was their ultimate conclusion. Repeat SLT is worthwhile even at 1+ year. At least it hints at more proactive regular SLTs, but it definitely didn't explicitly say that. So here's the ultimate. Even if the SLT doesn't last long as you had hoped, maybe it's only 1 to 2 years. It's on the short end of your bell curve. Go ahead and repeat it. And rest assured the repeat will work well. So even those where it doesn't work great the first time, the duration of effectiveness, go ahead and repeat it. How many times can you repeat it? I used to say like 2 to 3 repeats, like initial, repeat 1, no problem, repeat 2, okay, and then you get to repeat 3 and repeat 4, which is like your 4th and 5th treatment. You know, maybe it doesn't work quite as well. I no longer say that there's really not any max treatment. We're going to come back to that in just a second. There's no maximum. We are moving towards lower energy, do it more often, and repeat it more. That's where SLT is going currently. So in summary, SLT works 80 to 95% of the time, about takes the place of one medication, doesn't interfere with other treatments or meds. You know, there's a lot of positives with this, and it's definitely repeatable. So your glaucoma traditional paradigm, there it is. We started with this. Meds, ALT, surgery. You know, I would argue that this is now our new paradigm. And 1, 2, 2, 1. I mean, you can flip these, put SLT 2, put meds 1. You have got 2 wonderful first-line options, SLT and meds. Meds and SLT in either order. We've got MIGs mixed in. You've got your tubes and trabs and things like that. And don't forget about drug delivery as well. But that is our new paradigm. So, you know, I usually answer this question here, maybe, you know, via the chat box or the Q&A. If it was your eye, I've asked this question now hundreds and hundreds and hundreds of times. You guys are the experts. You're the optometrist. If this was your eye and you were the patient, let's say you're 65 years old and you were just diagnosed with glaucoma, what would you choose first line for your eye, drops or SLT? And there's no wrong answer there. I've asked that question hundreds and hundreds and hundreds of times. And Joe and Greg, I will tell you, always the answer comes back somewhere between 85 and 100%. It's usually between 90 and 100% of optometrists say, if it was my eye, I would want SLT first line therapy. Any thoughts on that, Joe, Greg?
Yeah, I mean, I've done similar in my glaucoma talks, and yeah, it's always at 85 to 90% that want to have the SLT over the meds if they had glaucoma as an optometrist and we're treating their eye.
Yep. So let's finish in our last 8 minutes here. A couple of, you know, low energy SLT, low power, low energy SLT. This has been studied out of Italy, among many other places before. And what do they look at? They looked at, all right, let's look at low energy yearly. Half the energy, half the shots, and do it every year. Half the energy. What do we mean by that? Well, okay, instead of 0.8 millijoules, 0.4 millijoules. Instead of 100 shots, let's do 50 shots over 360 degrees. There's your half half the energy, half the shots, but do it every year. They come in for their annual visual field, they get their annual OCT, and they get their annual SLT as well, okay? Then we got SLT normal energy as we described. Again, we described about 0.8 to 1 millijoules and about 80 to 100 shots, somewhere there. And when do you repeat it? Whenever you need it down the road. 2, 3, 4, 5, 6, 7, whenever you need it down the road, that's your normal protocol. And then they threw in ALT as well. They threw in ALT as well. Okay. And they looked at the ocular hypertension patients that did not need meds over 5 to 7 years, group 1, group 2, and group 3. Group 1 was clearly the winner. Who was group 1? Low energy yearly. Mean time to initiation of medical therapy, group 1, group 2, group 3. Which one was clearly the winner? Group 1, low energy yearly. This has been the rationale for the COAST trial. Big names in ophthalmology. The COAST trial is the clarifying the optimal application of SLT therapy. That's what COAST stands for. And it's basically looking at this low energy SLT. Look at these 10-year medication-free rates. Who is most likely going to be medication-free, drop-free 10 years from now? Low energy SLT. Half the energy, half the shots, and do it every year. And doesn't that make some sense? Let's get that immune system kind of fired up a little bit, get those trash collectors kind of fired up a little bit to clean out the junk in the trabeculum. Why should we do that every 6 years? Why not do a low energy every year to get that working for us and kind of that cleaning action working every single year? Again, that makes kind of intuitive sense there. So that's the COAST trial. This is where we think SLT is going. When the COAST trial is released, and I've heard some leaks that the data looks really good, not released yet though, we think this is going to be what the Light trial was for SLT. The Light trial just shoved SLT front line, and I think that's what the COAST trial is going to do, is going to shove low energy annual SLT first line. So we wait for the results of the COAST trial. Last thing I'm going to finish with is automated direct transscleral SLT. So I'm sure some of you have heard of this as well. I was at SECO in March of 2020. What happened in March of 2020? Nothing big, right? There was no like world events going on in March of 2020. Like the last big conference was SECO 2020 before the world fell apart. Okay. And I remember being at SECO, and at SECO, they have a sub-conference called the OIS, the Ophthalmic Innovation Summit, OIS. And it's all these companies. What's next? What's coming? What's in the pipeline? You know, what are we developing? And these companies have like 5 to 7 minutes to talk about their technology, whatever it is. And this company called Belkin gets up there. I'm like, Belkin. You know, they make routers, don't they? I don't know that they're in the ophthalmic space. It's a company in Israel, and they show a picture of this thing. And this is automated direct transscleral SLT. This is called the Eagle DSLT. The Eagle DSLT. It's automated. What does that mean? Well, you hit the button and it automatically fires the 100 shots. Automated direct transscleral. What does the direct and the transscleral mean? It means directly to the ocular surface. Directly to the ocular surface. Transscleral. Through the sclera is where the laser burns are going. The laser pulses are going. Go back to, there you go, your DSLT, your transscleral. You know, the TM is not too far from the surface of the eye. You just got to go through that kind of limbal scleral area, transscleral, direct. And I remember they showed a video of this. And it gets iris tracking, automatically aligns. It's automated. Tracks, all right, fixated, hit the button, and it fires 100 shots automatically. I'm going to show you the video in just a second. Fires 100 shots in 2 seconds. 2 seconds. How long does it take me to do an SLT? Like 2, 3, 4 minutes. Now you do this treatment in 2 seconds. Unbelievable. Automated direct transscleral SLT. I actually got my hands on this device last August, about 14 months ago. The FDA invited 24 doctors to Boston to kind of play with this kind of usability trials, navigate the menus. They invited 18 ophthalmologists and, to their credit, 6 optometrists. So I was one of the 6 optometrists. We got to play around with this and get our hands on the Eagle DSLT on Model Eyes, navigate the menus, etc., etc. Let me show you a video. Here's a video. By the way, what does this look like? What machine does this look like in your practice? When I ask an in-person live audience, there's always multiple people go, looks like an autorefractor, looks like an autorefractor, an auto device of some sort. Well, this is automated direct transscleral SLT. Putting in the details, select the eye, how many degrees, hit next. Here we go. Automated direct iris tracking. And ready. Here we go. And that's the start of the procedure and the end of the procedure. That was 100 shots done just like that. And I'll finish with, I always say, I don't know if I'm ever going to do an SLT. If you're one of those docs, you're going, if this is in somebody's office in the future, whose office does this need to be in? Yours. By the way, this was FDA approved in December of 2023. This was approved by the FDA. They were quite silent on this. And Elcon Surgical bought this laser in late April this year and is now starting to roll this out. This is FDA approved in the United States. So I will pause there and open it up for questions, comments, thoughts. Joe, Greg, interesting modality. I'm sure both of you have heard of this. It remains to be seen, how will this change things? Will it change the game? We don't know the price point on this yet. I've heard maybe there's click fees associated with this. We don't know yet, but how will this change the game when it comes to laser trabeculoplasty? We will see.
Well, before you go on, Nate, there are a couple of questions that came in. If SLT has pulse duration of 3 nanoseconds and melanin can't convert the laser electromagnetic energy into thermal energy, why does pigment matter so much?
Yeah, question is why? Because you need the pigment. The pigment actually absorbs some of the laser energy, and when it does that, it creates a little stress. On that area, and that is why you get that inflammatory response that is being generated there. So it does depend on pigment. However, they've looked at studies, and pigment is not a great predictive factor for success. We talked about pre-laser IOP. We talked about maybe the number of medications they're on. Pigment, some studies say it is, and many other studies say it's not. So, you want to play a role of pigment because the more pigment that they have, the more laser energy that gets absorbed, the more inflammation that's created. But I will do this whether they have a lot of pigment or whether they have light pigment there. It's selective for pigment. The melanin absorbs the laser energy. It just doesn't transmit into a thermal burn, creates a little stress. That's the inflammation.
Another question, with a new paradigm, why do any meds at all if SLT is done? Would the secondary meds actually help at all?
Well, there's no perfect treatment option, and SLT is not perfect either. It doesn't work in everybody. It works in the vast majority, but it doesn't work in everybody. I really view this as SLT is your first line. And don't forget that the MIGs there and drug delivery if they need a holiday from drops. And drops are really kind of supplementing when needed. I think as we do SLT more and more often, we're going to be using drops less and less often. It used to be SLT, do it. And then 5 years later, maybe we did it again. We were just so hesitant to repeat it because of ALT. Well, now that paradigm is changing. So I really view it as drops are there when I need them, and only if I need them, I'm going to control with SLT early. I'm not going to forget about MIGs. We've got drug delivery that's only going to get better as time goes on. So drops are just there kind of as needed as a secondary if and as needed.
Here's another question I think that we did touch on, and just to bear a quick repeat. I don't think we don't know the price point of the Belkin laser, correct?
I've not heard the price point of the Belkin laser yet.
Okay. And do keloid formers have more scarring?
I'm not aware of any study or literature that shows that there's a contraindication with keloid formers or more scarring when it comes to SLT. It is not a question that I ask in my preoperative period for SLT. I'm not aware of any major literature that says that. So no issues there.
Neither am I. I agree. I'm not aware either. I think that's it. We're caught up in questions.
That's fantastic. Nate, if you can stop sharing your slides. I'm going to share mine. Thank you for doing that.
Excellent.
I'm going to
Nate, we really
remind the
appreciate it.
audience that right here, there's a little red circle that you can now start answering that survey. I'm going to now move on to this slide where it says thank you and questions. Joe, are there any more questions?
No, we're good. No, hold on. Maybe there may be one more. Let me look for you. For insurance coverage, is there a minimum requirement of IOP, CD, field loss in order to justify SLT, or is just a diagnosis of glaucoma or ocular hypertension?
There's no requirements for IOP, cup to disc ratio, visual field. If you make the medical decision that a treatment is needed for whatever reason, SLT is covered.
All right. Well, Nate, as Joe and I like to do, we like to have people come in that not only know the procedure, but actually do the procedure. Obviously, you're one of the leaders around the country going out and teaching all these states, these 12 states that are out there that are passing these bills. I want to thank you for, again, the lecture, the role of laser in the treatment of glaucoma. I think it was fantastic and excellent. Looks like all the questions are answered. I want to thank you for being here. Joe, comments, and then Nate, comments.
No, I think it was fantastic. You did a very integrative type of talk that was enlightening, and you did draw the audience in. So I thought it was fantastic. Thanks so much.
I appreciate you guys, the invite. I respect you guys so much, and thanks for the invite. And I love the dialogue back and forth and picking your guys' brilliant minds, whether it's glaucoma or diabetes or dry, whatever it is. So I just appreciate the invite and all that you guys do.